So you finished the case on time, sir.
No, I handed over to my colleague and came.
Oh,
She finished after half an hour. So, but I thought I'd just come home, have a shower, and be ready. But after Corona, come home and have a shower. I think there's more hygiene nowadays everywhere.
true. So I'll just start with a small intro of yours, sir. 1 minute.
You? Yeah. Now I can see. Yeah.
Now you can see. So, okay, sir. We'll start off. Good evening, everybody, and welcome to Facebook Live challenge it's an initiative by the Anaesthetic Society. First of all, I'd like to thank Dr. Sanjay Prabhu, sir, for accepting this invitation. Thank you, sir. And we are happy to have you here amongst us for this Facebook Live challenge lecture. The topic is Pediatric Anesthesia, Tips for Occasional Pediatric Anaesthetist. So just to introduce you, sir, formally, because many people may be interested to know you. So Dr. Sanjay Prabhu finished his undergraduation from Stanley Medical College, Chennai, and finished his post-graduation from BJ Medical College, Pune. And so he worked as a faculty at SRMC Chennai, that is Sri Ramchandra Medical College, and then joined as a senior consultant at Apollo Children's Hospital for the last 7 years. Right, sir? Am I right?
6 years now, yeah.
6 years now. Okay, sorry.
Finishing 6 years. Finished 6 years, starting 7th.
Starting 7th. And he's a special interest in chronic pain and pediatric anesthesia. And I'm happy to inform all our group members that he was a very active organizing member in TACON 2018, and he was there any time when we had a meeting scheduled in the late evenings after his busy schedule. So thank you, sir, for accepting this invitation, and we'll share your screen, sir, now.
I think I'm ready to go, Surendra.
Oh, sure, sir. Please.
Yes, sir. Please, sir.
Okay, so share screen.
Yeah, you can share screen, sir. Yeah.
It says host disable share screen.
No, sir. 1 minute. Yeah. Can you see now, sir? Now, try to.
Yeah. Okay. Share. Can you see me?
Yes, sir.
Can you see the presentation?
Yeah,
yes,
you can
please.
make it full screen.
Yes.
Yeah.
Full screen. Yeah.
Yeah. Okay.
That's fine, sir. That's fine.
Okay. Really sorry, guys. Sorry for the technical glitch. So at least we can get started now.
No issues.
So can you all hear me clearly?
Yes, sir. We could hear.
Okay, so topic for the day is pediatric anesthesia for the occasional pediatric anesthetist. Okay, so I work in Apollo Children's Hospital in Chennai. It's an 80-bedded small hospital, so fairly small by many standards. We do approximately 4,000 surgeries per annum. I mean, when I mean surgeries, it includes out of operating room anesthesia as well. Between 3 of us, so average 1,200 to 1,500 per person. In this talk, I will try and cover whatever points I can in the 30-40 minutes. So I may not cover everything what you guys would expect, but I hope that you would learn at least a few points at the end of my lecture. So when it comes to defining who's an occasional pediatric anesthetist, I don't think there is a definite terminology yet. But some people say that if you do less than 100 cases per annum, that will probably be an occasional pediatric anesthetist. Now, the question comes is, how many of us are confident when we deal with children? In some situations, certainly, I'm still not confident. I have been doing pediatric anesthesia for the past 6 years, exclusively pediatric anesthesia, but still there can be some tense situations where I falter. So I think all of us do get better and better with age, with experience. So yes, the confidence comes with time, and providing we follow a systematic way of dealing with things. And as anesthetists, I think we do have a zero tolerance for side effects. So the more systematic and the more planned we are, the better the outcomes are. Now, what is a child as per the Indian law? Anyone less than 18 years is considered a child. This basically applies to when it comes to consent. Now, comparing to adult practice, does pediatric anesthesia have a higher risk? Yes and no. There are certain situations where pediatric anesthesia dealing with a child can be more challenging. And there are certain complications where the pediatric children do have a higher risk during surgery. Now, this is the only risk calculator I'm aware of when it comes to documenting the numbers when it comes to a surgical risk. So it is from this American College of Surgeons website. I think they do have an adult version as well. So for people who have not seen this, you can try. It's free for everyone. You can try this even for adult practice, and it will give you a risk for every complication based on the inputs you do on the screen. Now, when it comes to pediatric anesthesia, the risk can be classified as high risk, medium risk, and low risk. And as you see, age plays a fairly big factor. Okay, lower the child, higher the risk. That's one. And obviously, the other factors we know. ASA is more is a higher risk, and major surgeries do have a higher risk as well. But one of the most important things which they do mention in many studies is that the experience of the anesthetist who is dealing with a child does make a significant difference in the incidence of complications and possibly the mortality as well. So this is a study published way back in 1997, where it says that the number of complications per 1,000 patients anesthetized decreases as the experience of the anesthetist increases. So someone who does more than 200 children per annum, the risk is 1.3 as opposed to someone who does less number of children during the same duration. Now, I'm not dealing with neonatal anesthesia because I think it's a separate specialty by itself. What I personally feel is anyone who wants to do neonatal anesthesia should ideally be doing it in a teaching hospital where you have help in the event of an emergency, or you've done exclusive pediatric fellowship for 1 year or so, because they do have the highest risk among the pediatric age group. So how do you deal with this problem where you might have to do a small child, maybe a 2-month-old child, have another anesthetist to help you? Okay, so it's always important that even in adult patients, when you have a very high risk patient, I think it's worthwhile having a risk, having a help, and certainly don't have an ego when it comes to dealing with small children. Please do have a help handy. And when it comes to risk in pediatric anesthesia, most of the problems which happen usually occurs is related to the respiratory system or air-related complications. And as you see in this graph, the complications tends to increase as the age decreases, with the highest risk being less than 1 year. So what will I discuss in the next 30 minutes or so? So I will go through from the preoperative period till the postoperative period, and I'll try and give some tips which will help you in your practice. So we will go through the various stages of the preoperative period, starting from the anesthetic assessment till the post-op pain management. Right, so PAC is pre-anesthetic assessment, okay, pre-anesthetic clinic. Now, this is probably a very important aspect of perioperative care, particularly in children. The reason why I say that is when you deal with a child, you don't deal only with a child, you deal with 3 people actually, and sometimes even 5 people. Yeah, sometimes when you sit in the pre-anesthetic clinic and you see the patients, you want to see the child. Usually the mother is there, the father is there, and sometimes the grandfather, grandmother could also be there. Okay, but very importantly, you would probably have to deal with at least 2 or 3 people through the course of the operation and in the post-operative period. So it is very important to assess the anxiety levels of the parent and the child, okay, and use this opportunity to establish a rapport with the child, because this can make a significant difference when it comes to actual anesthesia. Okay, and as with any anesthetic practice, I think it's important to clearly explain the the course the child will go through over the perioperative period. Okay, so the more you explain the child and the parent, the less anxious they are. I think this applies to, again, even other situations. And it's very important to assess how cooperative the child will be, because this will determine the how you're going to take the child inside the OR on the day of the surgery. Apart from that, always ask for whether the child has had any previous admissions to the hospital, and if so, for what reason, and if they've also had previous surgery, because past experiences can make a significant impact on the child and the parent. And if they've had an unpleasant experience for whatever reason, the entire way you manage the children will change. Okay, so for example, when you have a child who's probably has had an unpleasant experience in the past, you might have to give some pre-medication to tide over the anxiety level. Okay, you might have to explain more to the parent and the child. Okay, so the approach tends to change if they've had a bad experience in the past. And children, unfortunately, they do carry these unpleasant memories for a long time to come. Okay, so this is our pre-anesthetic clinic. It's a small room there, but as you see, I bought these stickers from Amazon and I put it on the different surround on all the walls. And when some children they come in, you start engaging them by talking about animals, and you ask them what is this animal, and so on and so on. And you can start playing some games with the child. See, again, anesthetic assessment for a child, you will have to spend at least 10 minutes. Okay, don't rush. The longer time you spend, the more pleasant the experience is going to be. Okay, so take your time, explain to them, and don't see them in a hurry. Apart from that, as I said, airway-related incidents are quite high in children and probably the commonest. So you need to specifically look for factors which increase airway reactivity. Typically, a child who's had a recent URI in the last 6 to 8 weeks, and URI upper respiratory infections seem to be much more common in children. To the parents spoke, apparently that does increase the risk of respiratory events in the child. History of any allergy, atopy, asthma, all these again have a risk of airway hyperreactivity. Specifically, look for predictors of difficult airway. So when you look at a child, you can clearly say if they have a dysmorphic facies. It could be a Mongolian slant of the eyes. It could be abnormal ears. Okay, you could have a receding chin, and so on. And specifically ask for history of snoring, particularly now that we have an increasing incidence of obesity in childhood, and they do have a high risk of perioperative complications. And lastly, don't forget to ask about loose teeth. So when you assess airway in a child, and this applies to adult patients as well, always see them from the side. Okay, from the side, you can, to a certain extent, judge if they have a small mandible. You can see this child was difficult to intubate, and it's got a slightly receding mandible. And this child was also a slightly bigger child. He was quite difficult to intubate as well. And you can see there is a receding mandible. Now, one common question most of the parents ask when we see them in the pre-anesthetic clinic is, does the child have any long-term complications of anesthesia? Okay. And the fact that, first is, another thing is, you might have come through the literature saying that anesthetics are neurotoxic. So there have been a few studies in the 90s and implicating that anesthetic administration early in age does have some implications, particularly cognitive and behavioral outcomes in the children in the later life. But subsequently, we have two studies published. One is the PANDA study and the GAS study, fairly recent studies, which did mention that children having a single anesthesia of less than 1 year duration, there isn't any great difference in the cognitive outcomes or the intelligence quotient as they had measured it. But having said that, they only restricted this to children having a smaller duration of anesthesia or only one single anesthetic. If the same thing happens for repeated anesthetics, maybe they have some implications in the outcomes. So again, in children, we have something called this ASD. ASD is not atrial defect. It is autism spectrum disorders. Okay, this is a completely different class of children who can be quite difficult to handle. They can be socially isolated. They don't mingle with others. They can have behaviors ranging from very silent to being very extremely combative. So these children have to be managed differently. But even otherwise, normal children or children who've had a bad experience in the past can be quite difficult to manage, and they will not cooperate for anything, including you may not be able to see them in the pre-anesthetic clinic. They will not even allow you to auscultate. So you need to have some techniques to distract them, and pharmacological techniques if distraction doesn't work. So common sedatives which we use in children is triclophos, which is pedicloral, or dexmedetomidine as a pre-medication if we think a child will not cooperate. So the question comes is, if a child doesn't cooperate, can you restrain a child? In smaller children, yes. The commonest age group who cannot be, who will not cooperate is generally between 2 and 6 years of age. Okay, so if nothing works and if the surgery is important, I think it's okay to restrain a child. But above 7 to 8 years, try not to restrain a child. Try to make them cooperate as much as you can. And generally, if you explain to them, they generally tend to cooperate. But below 7 years, you can restrain a child. Older child, try not to restrain. Right. So when it comes to taking a child inside OR, one thing which very often we have found is, and we've had problems, is you give fasting instructions, but it's very difficult to parents see that a child is crying because of hunger. So they will say, I just gave a small amount of milk, little milk I gave, doctor. Just little, very little. So don't believe them. So it's always worthwhile asking if they've fed the child before you take them into the OR. And second is, very often when you see you taking the child from the parent, the mother starts crying. So it's always nice to speak some reassuring words to the parents saying that we will take care of the child, not to worry. You can do various techniques to take the child inside the OR. That can be a difficult task. So one is, all of us have mobiles, so you can play some videos, children videos, animal videos. Some children sort of, they start looking at that and they forget the parents, they come along with you. And we do have some small, a small car, which we tend to wheel inside the OR, which helps. So when it comes to fasting in children, there have been multiple studies showing that the risk of aspiration in children is much less compared to adults. So we are quite liberal when it comes to fasting. 4 hours for milk. And if it's less than 1 year, we tend to give even milk up to 3 hours before surgery. Clear liquids for 2 hours. And we say they can give water up to 1 hour. And it's, again, as much as possible, try not to keep children fasting for a long time. They can get really cranky. It upsets the child. It upsets the parents. Everyone starts crying. So as much as possible, try to plan your surgery according to that. They don't fast much. Now, is there a role of rapid sequence induction in children? Again, as I said, the risk of aspiration seems to be less in children. Unless you have an obvious child with a laparotomy with a lot of vomiting, we do recommend something called a modified or a controlled rapid sequence induction, where we tend to do a gentle mask ventilation and try and keep the airway pressures low. In that way, you also minimize the amount of desaturation during the apneic period. Okay. And when it comes to feeding after surgery, again, it's a very common question most of the parents are worried about. When can I feed my child? So you'll have to individualize. Some children, they wake up very quickly. So you can give them even water within 10 minutes, 20 minutes. So it all depends on how they wake up after the surgery. And it can be a very common reason why a child is irritable and crying in the post-operative period. So when it comes to establishing IV access, again, this can be one of the major challenges a lot of people are worried about, because one is they are more difficult than others to get an IV access. You can't expect a child to cooperate. Okay, so what do? Do you do it before induction with the child screaming? Or do you do an inhalational induction and then get IV access? Again, it all depends on the situation you are in. If you think you are the only person there, you don't have help, and if you think the IV access is difficult, then if you land up in a situation where you do a mask induction, you don't have an IV, you're struggling to get an IV, you don't have a technical help, your anesthetic technician cannot hold a mask properly, you might have a situation where the child is obstructing, you don't have an IV, and you start getting tensed. Okay, so if you think a child is going to have a difficult IV, I would recommend that you secure the IV before the child has any kind of induction. If you think the child has got a glaringly obvious IV when you look at him, then you can go for a mask induction. Second thing is, do you have a parent? Will you have a parent? Again, you need to judge the anxiety levels of the parent. If you think the parent is very anxious and that is going to make the child even more anxious, no parent. That's one. Second is how comfortable you are to have a parent. If you're not comfortable, don't have the parent. Okay, so again, there are a few factors to consider when you have a parent, whether to have a parent. I personally have a parent if I think the child will cooperate with the parent in presence. And some parents can talk to the child and even make them accept an IV. So it all depends on how the parents are. Okay, and as always, it's recommended that you put an Embla cream to minimize the pain of venous cannulation, particularly in children who think you will cooperate. And finally, use any form of distraction to get an IV access. So that is a video of a child. Obviously, he's quite, we try to distract him with some video on the phone. And nowadays, most of the children, as you know, they like mobiles. So obviously, we were able to get this child inside OR and also accept a mask induction, but keep watching. At this point, he's refusing the mask. Yeah. So we need to use some restraint. Finally, we had to use some restraint. Okay. But again, the levels of cooperation can vary significantly among children. Some, they will not even come with you. Okay. Some will come with you. They won't have a mask. Some will come with you. They will accept a mask. So you need to judge this by the child. Now, so when you have difficulty in venous access, how do you, this is one thing, again, you would want to check when you assess a child in the pre-anesthetic clinic. So in children, many of times you cannot feel a vein like in others. I mean, you may not be able to see a vein, but you can feel a vein as a bluish tinge. And you need a good assistant to help you to secure the venous access. So in many situations, even last night I had a foreign body for a child, a 1.5-year-old child weighing 24 kilos. Would you believe it? A 1.5-year-old child weighing 24 kilos. And there was no venous access I could see. And I was alone in the hospital. We just had one technician with me. So in situations where you think the venous access can be difficult, there are certain places in the body where you can look for. One is the external jugular vein. That's one. And second is the common vein, which is taken by most anesthetists in difficult accesses, saphenous vein, because it is present at the level of the medial malleolus, and it's fairly constant position. So you could just blindly go there and you might hit the vein. That's number two. Scalp vein in very small children. And I have this transilluminator, which is basically a bright infrared light, which can be used. So that's the transilluminator. And on the right, you can see the image of the dorsum of the hand. Obviously, the veins are not very clearly seen here, but in the actual image, the veins were well seen. So this equipment can make a huge difference when it comes to securing venous access. Okay. Some people have tried using the fiber optic light source, which is used by the surgeons. Be very careful because this is hot. It can cause burns in the child. Okay. So if you're going to use this, have a gauze underneath and then use cover the light source with a gauze and then use it under the patient's palm, and you can see if the veins are evident based on that. Okay, in very small children, like in neonates or infants, less than 2 months, you can use your one hand to be as a tourniquet and to hold the hand and stabilize the hand. So this is one child where we couldn't get access anywhere, and finally we got an access in the anterior abdominal wall. Sometimes children are very dry if they have been fasting for a long time, or the parents have not followed your instructions. The child could be dry, so it might be difficult to get an access. So in these situations, once you secure a small vein somewhere, give some fluids, and then the other veins pop up, and then you can get a better access. Now, again, when it comes to the tricks of inhalation induction, people do it different ways. But generally, if we think that the child is uncooperative, it is quickest done with nitrous oxide. Because obviously, due to the second gas effect, when you use nitrous oxide, they tend to go to sleep within 30 seconds or maybe 40 seconds. The second point is some people, they start with, if you have a cooperative child, you can always start with 2% sevoflurane and slowly, gradually increase it. So that it's not, even sevoflurane, if you have tried inhaling sevoflurane 8%, it can be quite pungent actually. So start with 2% and slowly go up to 8%. But if you have an uncooperative child who has to be restrained, I would just give 60% nitrous oxide, 8% sevoflurane. Within probably 40 seconds to a minute, they're asleep. Now, during inhalation induction, there are certain precautions you have to be careful about. The child might obstruct. So what do you do when a child obstructs? Never do any painful procedure like an extreme jaw thrust. If you give a jaw thrust in a child who is not fully anesthetized, they will go in for a laryngospasm. Okay, you don't have IV access. Okay, child is obstructing, you're giving a jaw thrust, child goes for laryngospasm, you are in a crisis. Okay, so when you don't have an IV access, whatever maneuvers you do, try and be very gentle as possible. And second thing is, what happens with inhalation induction, as the child becomes deeper and deeper, the respiration tends to slow down and even becomes shallow. So some trainees I've seen, they start assisting the child, they start bagging. Never do that, because it's a what do you say? It's a compensatory mechanism by the body. As they go deep, the respiratory rate and the depth becomes shallow. So the speed of induction tends to go down. So it's sort of a protective thing by the body. So at that point, you don't start squeezing the bag and pushing in more volatiles. You might cause severe hypotension. Okay, so when you're trying to ventilate, you have a 1-year-old child, recently had a URI, okay? You've got an IV access earlier on, okay? You're not doing a mask induction, child has got an IV already. You give propofol. As soon as you inject the propofol, the child stops breathing. You're trying to ventilate, you're not able to ventilate. So what is happening? This is a very common situation, a very common scenario which we encounter when you give IV propofol quickly. So there's a terminology called functional airway obstruction. Okay, we all know the causes for anatomical obstruction like tongue falling back, epiglottis falling back. But in children, functional airway obstruction is far more common than anatomical obstruction. And the commonest cause for functional airway obstruction in children is laryngospasm. Okay, and whenever you inject opioids like fentanyl or propofol quickly, they will cough once or twice and they will stop breathing. And when you try to ventilate them, you cannot ventilate them. So it's typically called opioid-induced glottic closure or propofol-induced glottic closure. And other thing which can happen is bronchospasm. Okay, so what do you do if a child obstructs during induction? You open the mouth and you do a gentle jaw thrust. And other thing is bag mask ventilation in small children. In children, we have between 1 and 7 years, they have a large adenoid. Okay, so unlike in adults, when you place a face mask and you try to ventilate with the mouth closed and a large adenoid sitting at the back of the nostril, you cannot ventilate. So the logical movement there would be to open the mouth. So in small children, if you're not able to ventilate adequately with a closed mouth, open the mouth. That will push air through the mouth instead of pushing it through the nostrils, where you have a large adenoid sitting in the back of the throat. And you ventilate only to see a visible chest rise. Don't be very aggressive with ventilation. If you do a large tidal volume ventilations, what could happen is you will push air into the stomach, and children being predominantly diaphragmatic breathers, the increased air in the stomach will splint the diaphragms, and it can cause basal atelectasis. Okay. This, all of you know that mechanic cause of airway obstruction, it could be a large adenoid, large tonsil, tongue obstructing, okay, inadequate head position. And yeah, gastric hyperinflation, again, it's very important, particularly in a situation where you're having a difficult airway. So make sure that when you do an airway maneuver in a small child at intubation and extubation, expose the chest and the stomach. Okay, you don't want a large stomach causing diaphragmatic splinting. So when it comes to tubes, we have two kinds of tubes, cuffed tubes and uncuffed tubes. Earlier, it was uncuffed tubes were the norm, but nowadays cuffed tubes is the trend. And there is this is for various reasons quoted. One common reason is when you use a cuffed tube, there isn't an increased risk of complications. And secondly, if you put an uncuffed tube in a child, and if you think that the tube is small, what do? The next response will be you change the tube to a bigger size tube. So automatically you do laryngoscopy twice. So everything happens twice. So there could be high risk of complications. And things like laparoscopic surgery, giving PEEP to the child, can all be difficult with an uncuffed tube. So a cuffed tube seems to be the norm nowadays, including neonatal surgery. And there is a special kind of tube called the microcuff tube, which is used in small infants and in surgeries where duration is quite long. Okay, so this is the microcuff tube. So how is this different from a normal tube? So if you see in this picture, that's the microcuff tube. The cuff is placed distally. Okay, see, that's the cricoid there. That's the vocal cords, and that's the subglottic region. Yeah. So with the microcuff tube, because of a more distally placed cuff, it sits below the narrowest part of the glottis. So the risk of mucosal damage is less likely. And also, the pressures required to adequately seal the trachea with a microcuff tube is much less compared to a normal tube. Okay, so there are so many surgeries in children where you would have a doubt whether you want to use an LMA or just hold a mask or intubate them. A classical example would be a tongue tie surgery. A tongue surgery, it's a fairly small surgery. Again, it depends on your surgeon. So in pediatric surgery, you need to know who your surgeon is. You have to decide so many things based on how good your surgeon is or how bad your surgeon is. So if you have any doubt about airway in a child, intubation is the best way to go. Having said that, if you think you're confident of intubating a child, then the risk of airway complications seems to be less with less invasive airway. If you have a child coming for circumcision, you do a good caudal, okay? You don't have to even put an LMA. You can just have a Hudson mask and give some sedation to keep the child quiet, and the caudal will do the job for you, okay? Less invasive airway, less complications. Having said that, if you're in doubt, intubate, okay? Now, this is a technique which we quite commonly follow in difficult airway patients. So the person who's doing the laryngoscopy and the person who's giving the external laryngeal manipulation will be the same person. And in smaller children, the neck being so small, if you ask another person to give manipulation or the pressure on the neck, you're looking at the laryngoscopic view, he'll be giving pressure, so it doesn't sync properly. So the same person does the laryngoscopy and the pressure on the neck, another person intubates from the side. This technique is quite useful, and we found it quite useful. Okay, this is a circuit which is commonly used. It's a Jackson-Breeze circuit, and yeah, it's quite helpful because it's portable, light, minimal valves. So another common thing which people can misjudge is the timing of extubation in a small child. Okay, and most of the complications which happen in small children, particularly airway-related complications, the highest risk is at extubation, not intubation. Okay, so you need to be fairly good you need to have a good timing when it comes to extubation. So in small children, when you see the face, they're trying to cry. Okay, when you see the face, they're trying to cry. That's a fairly good indication you can extubate them. Okay, and the other thing is you judge adequate muscle power by looking at the legs. They will start kicking their legs actually. Okay, apart from the other things like a normal vitals, adequately reversed patient, these two things is something which we go by, and you will not fail if you go by these things. So this is something I've got this two lines from Dr. Ramesh. He's a senior pediatric anaesthetist in Chennai. S. Ramesh, you might have heard about him. He's been doing anesthesia for almost 30 years, only pediatric anesthesia. So he's mentioned these two things. In a child, when it comes to airway management, if in doubt, intubate. I already mentioned this point a couple of slides ago. So whenever you have a doubt whether to intubate or not, better to intubate. Okay, you have a surgery in a hernia in a small child who's had a recent URI. Okay, you're not sure about the surgeon. He might take 40 minutes. He might take 1 hour. Okay, your caudal, you've done the caudal. It may not work. Okay, you put an LMA. Child goes for a laryngospasm. So all these can be avoided providing you plan ahead. So if you have any doubt that LMA may not work, just intubate the child. Likewise, in small children, timing of extubation, if in doubt, do not extubate. Okay, because extubating prematurely can lead to complications. Yeah, one thing which I did mention is loose teeth. So children with milk teeth, always there is a potential for them to become a foreign body. So be aware of it. This is something which we routinely do in our hospital. Once we did forget a throat pack and we managed to find that out in recovery. But yeah, whenever we put a throat pack, we just put a label on the forehead so that we know that there is a throat pack. IV fluids, gone are the days when we use dextrose-containing fluids, nor do we use half normal saline. So like in adults, we use plasmolite or ringalactate. In neonates, we use 10% dextrose because they have very poor glycogen stores. So when you do a central line in a small child, when you go with a needle into the patient, the needle per se can compress the vein and you cannot aspirate blood. So best thing is you go to a certain depth, and then as you withdraw the needle, you will see the blood coming back. So you're more likely to aspirate blood when the needle is being withdrawn instead of when the needle is being inserted. And obviously nowadays it's a recommendation that in small children use ultrasound. Okay, when you extubate a child, again, as I said, extubation is the time of highest risk when it comes to complications. Always expose the chest and abdomen so that you can quickly identify if a child stops breathing. Secondly, always have a tube handy in case the child needs to be reintubated for whatever reason. Have another tube, preferably a smaller tube handy. And all pediatric anesthetists, if you ask throughout the world, will always have 2 drugs ready in the anesthetic trolley. One is scolin, other one is atropine. Even atropine is okay, you don't have to have atropine, but scolin is mandatory whenever you practice pediatric anesthesia because the incidence of laryngospasm, which is probably the commonest complication you will encounter when you do children regularly, and the best treatment for laryngospasm would be to give scolin. Okay. Now, this one, if you see in this picture, on my left hand, I'm holding the mask on the patient's face, and on my right hand, I'm holding the reservoir bag. The reason I do that is, in small children, this is immediately post-extubation. Okay, so in small children, the moment you extubate and you place the face mask, one is by holding the reservoir bag, you can judge if the patient is breathing, and you can appreciate very small respiratory excursions only if you hold the bag. If you don't hold the bag, or if the bag is dangling somewhere down, you might miss that actually. So one is to hold the reservoir bag in your right hand and keep the apial valve partially closed. Okay, this will also decrease the risk of laryngospasm. Okay, I always put all children on the recovery position. Okay, because children have a high risk of obstruction, a larger tongue, a smaller mouth. Okay, so they can obstruct. You might think you've extubated correctly. Okay, you put them on their back, you shift them to recovery. There you find the child is desaturating. So always shift them in the recovery position. Okay, this is a child who's had a hernia a 1-month-old child. Child had a good working caudal. See how comfortable the child is. Okay, extubated, breathing quietly, the vitals are stable, there is no tachycardia. Okay, so if you can achieve this in a child in recovery, you're probably the best anesthetist. Yeah, so but again, so the reason I'm trying to make now is pain in pediatrics. Okay, in children, pain has to be treated aggressively. Why? Okay, this is a very important slide. Okay, one is, if you don't give adequate pain relief for a child, particularly in small children less than 6 months or 1 year of age, there is significant long-term changes in the brain, which makes them more susceptible for higher amounts of pain for any surgical stimulus or any pain-related problems later on. Okay, so an inadequately controlled pain in a young infant leads to a permanent lowering of the pain threshold because of changes in the brain. Why they have a high, and this is one point, and second is children have per se have a lower pain threshold because the descending inhibitory pathways of pain are inadequately developed or immature. Okay, suppose I pinch you, okay, you start feeling pain. The next thing what happens is, from the brain to the spinal cord, there are some pathways which decrease the amount of pain, and subsequently the pain tends to decrease in intensity. In children, this descending inhibitory pathways for pain is immature or not adequately developed. So a pain which lasts only for 20 seconds in a older child will last 40 seconds in a smaller child. So that's why it's very important that you do all measures possible to decrease pain in children, particularly in smaller children. Okay, so the next point is, in children, wherever there is a nerve, I try and block them. Do a regional block wherever possible. It's a huge help for the child. Okay, it makes a big difference in terms of how the child is going to come out of anesthesia. A good block, you have a comfortable child, you have a happy parent. And as with others, use multimodal anesthesia, use paracetamol, brufen, regional anesthesia where possible. Embla cream, something which we use, particularly in children who you think will cooperate for an IV cannulation. You tell them that this will numb your skin, and it makes venous cannulation pain-free. Yeah, one thing which children don't like is you've done an IV cannula, okay, and they would think, okay, that's done, yeah, no more pain. And the moment you inject propofol, they start screaming. Okay, you don't want that happening. So always add lidocaine with propofol whenever you give it to a child. This is a child ready for a caudal anesthesia, but you can see there is a hemangioma there. So any landmarks over the sacrum, it could be a tuft of hair, a sacral dimple, or a hemangioma like this. It could be a feature of spinal dysarthrism. So when we see this one, generally we use an ultrasound machine. So again, ultrasound machine has become the norm for most of the peripheral nerve blocks. But for caudals, generally we do it blind. But if you see such things, generally we use ultrasound to make sure we can see the space and there is nothing in the path of the needle. Okay, look at this child. This is a video again. This child had a circumcision, okay, but we did not do a caudal. Okay, this is how a small child will exhibit pain. They will have what is called an opisthotonus. Yeah, so I'll play the video, you can see for yourself. They will arch their back and they'll have stiff limbs. This is how you identify a very small child with pain. Child is crying, it's arching its back in an opistotonic posture, and you see the circumcision is done and the caudal wasn't given. Yeah, so the surgeon did a different technique and he said caudal will not be required. But finally, I think he was wrong. Heart rate was around 200 for this child, certainly in gross pain. So I think this slide, most of you know, all of you are very good when it comes to pain relief. But multimodal, so in most children, we give a combination of paracetamol and brufen, either in the form of syrup or suppositories. We try and minimize opioid usage, and adjuvants are used along with regionals wherever required. Okay, this is one of the blocks which we do commonly for penile surgery. It is called the pudendal nerve block. So if you see, that's the child in the lithotomy position. That's my probe. So we go out of plane technique. And if you see here, that is the ischial tuberosity. That hypoechoic shadow is the anorectal shadow. And that is called the ischiorectal fossa. Okay, so the pudendal nerve runs in this fossa. So basically, we go out of plane technique, place the needle here, and inject the drug. Seems to work quite well. So we have one surgeon who wants this surgery. Wants this block for hypospadias because he believes that with the caudal they tend to bleed more, and there are some papers quoting a high risk of fistula formation with caudal blockade. So we use this routinely for some surgeons for penile surgery, particularly for hypospadia surgery. Again, this is a very common thing which you see in children. So when you see a child in recovery, they will be screaming, okay? They will be thrashing around. They will not look at the parents. The parents will not be able to console them. So this is called an emergence delirium. It is again very common in the younger population between 2 and 7 years. There are certain risk factors for emergence delirium. So one is excess anxiety levels, previous unpleasant experiences in the hospital. Inadequately treated pain can also be a cause for this one. So you can pick them up by lack of eye contact, okay, inconsolability, and there would not be any purposeful movements. So this can be prevented by making sure the child has got adequate pain relief, and a small dose of propofol at the end of surgery does decrease the incidence of emergence delirium. And this dose of propofol also tends to decrease the risk of laryngospasm. Okay, this again is common in children than in adults. I'm sure all of you know this. So we routinely go for dual antiemetics. Non-operating room anesthesia, very commonly we do CT and MRI. Most of them are managed by propofol infusion. Sometimes we also give triclophos syrup orally in the dose of 100 milligrams per kg, or nasal dexmedetomidine, just 1 to 2 mics per kg. With 2 mics, generally there is a slightly slowing of the heart rate, and they will sleep for a longer time. So 1 is preferable, but some children may not respond to 1, so you might have to give 2. Children have very gentle skin, so and children as a group, they're very gentle. So try to be more gentle with them. This is a child who had this surgical drapes, disposable drapes. It has a sticky thing at the end actually. So when they removed it quickly, it peeled the skin off. So just be aware of that complication. And see, compared to, I've worked with adults for almost 20 years, adult surgeons. Compared to adult surgeons, pediatric surgeons are a lot more sensible, a lot more amenable to suggestions, and they see complications which are happening so frequently. And many of the surgeons, they will see you doing intubation and extubation. They will be there, okay? Because they've seen so many children going for bradycardia, and how quickly they do get corrected by by some basic measures. So if you think a child is not fit for surgery, please discuss with them. They are usually okay to do as you say. And many of them, they do respond to whatever you say. They say, as long as you think the child is fine, we'll take it up, doctor. So don't hesitate to discuss with the surgeons, and know your surgeons. Each surgeon is different. Yeah. So I think to summarize, you need to be aware that airway-related issues are probably the commonest cause for problems in children. And never have ego when it comes to anesthetizing a small child, or if you think you cannot manage the child on your own, always have a second anesthetist to help you. Smaller the child, for any surgery, the risk is higher. Aggressively treat pain. And importantly, don't forget to that you need to also deal with the parents. Okay. So this is one of the consultant anesthetists. He's a cardiac anesthetist. So if you see, we are in the CT scan room. It's a very small child. So obviously, I'm taking the picture. So it's a very small child with a cardiac defect. So obviously, two consultants went to, though it's only a 5-minute procedure, which still things can happen so quickly in children. So I took his help to do that. And something which I commonly tell the parents is, once I take the child from you, it is my child. So don't worry about it. I will take care of the child as it is my child. Thanks so much for listening. And I'm happy to answer any questions you guys have.
Well, thank you so much, sir. It was a wonderful presentation. And there are a few questions
Sure.
from the audience. The first is from Dr. Girijanandan Menon. And he asked, do you recommend to use roller under the shoulder or pillow under occiput while intubating?
Yes. Okay. So children, when it comes to airway management in children, less than 2 years seems to be the children with a higher risk. Okay. And until that age, they have a larger head. So up till 2 years, or if you think they have in children who have a very prominent occiput, it's worthwhile having a small roller under the shoulder so that you can maintain that angle. The angle between the external auditory meatus and the mandibular sternum should be at the same line. So in children less than 2 years, a shoulder roll for intubation or airway management will help. Yes.
Sir, Dr. Unmesh Bedekar, he has few questions. Like, will you suggest a throat pack instead of changing the tube?
Yes. Again, see, it depends on what surgery it is, how long the surgery is going to be. See, if it's going to be a 20-minute surgery, okay, it's not a laparoscopic surgery. You've had difficulty into getting the tube in. Child has got a recent URI. So all these things have to be considered. Okay. If you think it's a longer surgery, a 4 to 5 hour surgery, child has got a large leak, then you might have to change the tube for a bigger tube. But a throat pack is a good idea. Where you think it's only a small surgery, why unnecessarily do another laryngoscopy, put another tube? Put a tube. If there is a small leak, you can put a throat pack around the tube to minimize the leak. Yes, it is something which we do instead of doing another maneuver all again.
Okay, one more question from Dr. Unmesh, that what is the cost of microcuff tubes, sir?
Okay, so they cost around 900 rupees.
Okay. So Dr. Hetal has a question for you.
Sure.
Do you recommend a deep extubation to avoid laryngospasm or bronchospasm?
Yes, again, it's one of the recommended measures. I think some pediatric anesthetists do that routinely. Depends on what surgery it is. Okay, let's say it's a inguinal hernia surgery or a orthopedic surgery. You can extubate deep if you think the child has got a risk factors for laryngospasm. So if it's a recent URI child with asthma, okay, a deep extubation is something which we do. The same situation, suppose you have an obese child or a child who is difficult to mask ventilate, or a child who's had a tonsil surgery where there is potential for blood in the airway. In these situations, you probably have to be a bit more careful when it comes to deep extubation. So it depends on the how likely they are to mask ventilate, and so on. Yeah.
Okay. The next question is from Dr. Prema, and during this COVID situation, hello.
Yeah.
Do you recommend using circle absorber, or do you recommend to use JR circuit?
Okay, fine. Yeah, I specifically didn't talk about COVID because there is so much COVID news. Specifically, I didn't want to talk anything about COVID in this talk. But yes, now because of COVID, we try not to use the Jackson Breeze. We go straight for a circle for induction also. Having said that, in small children like neonates or 2 months, 3 months, it is a lot more comfortable using a Jackson Breeze because I think the ventilation is easier. You can control the ventilation easier. So with very small children, we still use Jackson Breeze, but other children we go for we have changed the practice more towards using a circle system, even for induction, even for inhalation induction.
And Dr. Deepthi Mehta, she's asking, what is your choice of fluid in pediatric anesthesia? Maybe you can minor surgery or something.
Minor surgery is ringer lactate. For major surgery, plasma lactate.
plasmolite. So there are
because
some
plasmolite is more balanced than ringer lactate. So whenever you think, like today we had a 8-hour surgery, just finished at 5 o'clock. It was a massive tumor in the pubic region. So where you think there's going to be a lot of fluid shifts, plasmolite is supposed to be a more balanced fluid compared to ringer lactate. So we go for plasmolite, but it's more expensive. So for surgeries lasting less than 1 hour, usually we go for ringer lactate. We don't use dextroskinetic fluids at all.
Okay. Okay. Sir, Dr. Vaishali Bhatta has suggestion, should we use isolite T? That commercial preparation.
Yeah, I know, but it's no longer recommended as a fluid. Actually, they say these two are good enough. Actually.
Okay.
So most of the hospitals we don't have isolate P in our hospital.
Okay. Thank you. And Dr. Unmesh has one more question. Like, what is the recommendation on usage of clonidine in infants?
Okay, so less than 6 months, I don't use clonidine. More than 6 months, we use clonidine. Less than 6 months, if it's obviously there's a risk of if it's a day surgery, we don't use clonidine. If it's going to be an inpatient surgery, so the child is going to be monitored, we can use clonidine. But generally, we try not to use for less than 6 months.
And Dr. Ashit Vaishnav and Dr. Manisha Ghosh, they have some comments on diclofenac usage.
Yeah.
They don't recommend to use less than 6 months, and Dr. Ashit says that it is not supported by literature. So what is your comment on usage of diclofenac in pediatrics?
Okay, see, diclofenac, brufen, all NSAIDs for that matter. Yeah, so some studies do say that above less than 6 months, it can have an impact on bone development. Okay, but personally, in our hospital, what we do is less than 3 months, we don't use these. About 3 months, we use diclofenac because in children, again, we are quite limited as to what we can use. Apart from paracetamol and a good block, many times we don't use opioids. We try to minimize opioid usage. So about 3 months, we use NSAIDs and paracetamol.
So one last question from Dr. Kandasamy, sir.
Yeah.
He says, URI, how long to wait in pediatrics?
Okay. There's no simple answer for this one. Okay. Though the books say 4 to 6 weeks, they do have an increased risk of upper airway events. I don't think it's practical to wait for 6 weeks. Okay. Many patients, at least who we encounter, they travel quite far away from India. They come from the Northeast, they come from Bangladesh, expecting a surgery. They've had infection 1 week ago. You can't ask them to go back and wait for 6 weeks. So what we do is we just take more precautions and make sure that we take all the precautions to minimize the risk of upper airway events. So less invasive airway, adequate pain relief, deep extubation, and have scoline ready.
Okay.
But we will cancel the patient if the child has got active URI like fever, purulent sputum, chest signs. These are definitely no signs for cancelling the case.
So he has one more question, sir. Do you still use precordial stethoscope?
No, we don't. But I think some people do use it for various reasons. But we personally don't use it. No.
Thank you, sir. Thank you so much for your hello.
Yeah.
For your excellent presentation, and
Thanks.
I think our audience would have thoroughly enjoyed the presentation by you.
I hope.
Yeah, Dr. Hetal, sir, you want to comment?
No, thank you very much, Dr. Sanjay. It was an excellent presentation.
Thanks.
There are few questions, other questions also on Facebook, so you can answer it whenever you are free. Thank you very much.
Sure. Yeah. Thanks for having me. Thank you. Good day.
Bye, sir. Bye.
Bye-bye.
Bye.